Welcome to Late Night Lectures Part 2. Another day after a 10.5 hour shift. So if I'm stuttering or exhausted, there's a good reason. It was busy today. We're going to be talking about Chapter 22, anticonvulsants, anti-Parkinsonian drugs, and agents for Alzheimer's. This is a lot of ground to cover in one chapter, but that is okay. We're going to get through it. Seizures. Let's start with those. Anticonvulsants, to convulse means to seize, anti means against, so these are drugs that treat seizures. Seizures are brief abnormal neuronal discharges in the brain that occur repeatedly and without warning. Seizures can involve altered consciousness, altered motor activity, or sensory impairment. Epilepsy is the most common neurological disorder in the United States after migraine, stroke, and Alzheimer's disease. So seizures are classified based on their type and severity and the cause. Sometimes there is no cause, and sometimes they just can't figure out what the heck this type of seizure is, hence number 3, atypical or unclassified. The other two are more identifiable. Generalized, they are bilaterally symmetrical and without local onset. This means the entire body is involved. They are further classified into smaller categories. Partial seizures are also known as temporal lobe or psychomotor seizures. They're usually limited to one hemisphere of the brain, one side of the brain, and involve no loss of consciousness or loss of consciousness, divided into simple or complex. So you need to make sure that the right type of medication is being selected for that particular seizure. Certain medications can treat certain types of seizures but aggravate others or have no effect on treating them. So generalized seizures, let's go back to those subclassifications. Tonic-clonic, tonic or tonic-clonic, or non-convulsive, which is absence, myoclonic, or atonic. So tonic-clonic, generally called grand mal seizures, and absence seizures are generally called petit mal seizures. And these usually covers about 40% of patients that have epilepsy. So tonic means tension or contraction. So when a patient starts to curl their limbs in during a seizure. Clonic usually means the relaxation of the muscles, and it can alternate back and forth between the two. These attacks usually last 2 to 5 minutes. Incontinence can occur. People lose complete control over their body. During the recovery period or afterwards, patients may complain about being sleepy or having a headache. They're usually a little bit sort of out of it. Really, treatment involves preventing injury right off the bat, making sure the patient's in a safe place so that if they start seizing, they're not going to hit their head, they're not going to hurt themselves. Usually don't try to force anything in the mouth or between the teeth. That was an old school treatment. Seizures that are prolonged or so frequent that the patient does not regain consciousness between seizures is called status epilepticus. So when somebody shows up to treat this patient, usually EMS, or maybe if they're in a hospital, or if they have a pre-existing condition and they have medication that's used for emergencies like this, usually IV lorazepam or sometimes diazepam rectally administered if you can't get an IV line. Those are the drugs of choice. In addition, you'll also want the patient to be on a phenytoin or fosphenytoin dose as well, sort of to keep them stable. The lorazepam is going to stop the seizure. The phenytoin is going to prevent further ones from happening. Absence epilepsy, remember these are called petit mal. These are brief 10 to 20 second loss of consciousness with no falling, and they usually occur in children. They're not associated with post-recovery drowsiness. Imagine someone just staring off into space and not really being able to respond to you. Febrile seizures. These are seizures very common to babies and children, usually between 6 months and 6 years of age. And usually it happens when the child is sick and has developed a fever, and the fever gets so high that they have a simple single brief seizure. Usually treated with acetaminophen or ibuprofen to bring the fever down. They're not as harmful as epileptic seizures. They are scary to moms and dads. However, they're brief. Usually they're a one-time occurrence and it never happens again. Partial seizures, also known as psychomotor epilepsy or temporal lobe seizures. We're going back to number 2 here. These last anywhere from 10 seconds to 5 minutes and can involve confusion, impaired understanding and judgment, as well as some purposeless movements, bizarre behavior, and weird sounds. No convulsions though, no full body shaking. Let's see. So drugs for generalized and partial seizures. Usually prophylaxis or preventative measures are taken after the patient's been diagnosed with a chronic condition, and they usually include valproate, lamotrigine, levetiracetam, carbamazepine, oxcarbazepine, or phenytoin. Drugs are titrated to achieve control over the seizures, and without preventing too much oversedation. A lot of these medications can be sedating. So let's talk about phenytoin. This is a rough drug, great for treating seizures. It's been around forever, great for preventing them. However, has a lot of side effects and drug interactions too. Side effects can include sedation, dizziness, headache, blurred vision, gingivitis, which is inflamed gums, GI distress, rash, Stevens-Johnson's, which is a rash that shows up shortly after starting the medication and can be very bad, inflammatory rash, as well as bone softening or, again, weakened bone density. We want to be careful in patients who have kidney or liver disease, diabetes, heart failure, bradycardia, pregnant patients, those who are lactating. We don't want to abruptly discontinue this drug. And as I mentioned before, there's a ton of drug and food interactions, so these patients are generally need to be well educated about the medication that they're on. Let's see, side effects of carbamazepine. And they don't cover the side effects of every drug, so if you're ever curious if your patient's on these medications, look it up. Pull up clinical pharmacology or Lexicomp or whatever your hospital may cover, your nursing home or wherever you may be working, and look up the side effects. I'm actually not going to go through them because you're never going to remember them. The idea is just to see the names and recognize that they are seizure medications. Sometimes these medications will also show up in the treatment of bipolar disorder, sometimes with different forms of psychosis. An example here would be Depakote, not just used for seizures, also used for some other neurological problems. So drug therapy for febrile seizures, we already talked about really controlling the fever if necessary, if it's lasting for a long time. And you can't get the fever down, diazepam rectally administered can be used. So, drug therapy for absence seizures. There's really one drug of choice, and that is ethosuximide. It's effective only for this type of seizure, and it lacks some of the other side effects that come along with drugs such as valproic acid. Other drugs can be used, it's just not as common with absence seizures. Normally the drug that you would use is ethosuximide. Other drugs that might be included, Klonopin, valproic acid, lamotrigine, but we always start with that one. Okay. Second generation anticonvulsants. These are newer, hopefully a little kinder medications with less side effects. Gabapentin, lamotrigine, levetiracetam, oxcarbazepine, and topiramate. They're used for the treatment of partial and generalized seizures. They're not considered superior to first generation. However, they usually don't require drug monitoring. Like I said, they have fewer adverse effects. They all require a slow titration period to avoid central nervous system adverse effects. And also, lamotrigine has that side effect of Stevens-Johnson's rash as well. We talked about that a little earlier. It's inflammatory, it's bad. It generally is a reason to stop a medication and never start it again. So table 22.1 has a great chart for first and second generation anticonvulsants. You can review that. Don't memorize doses. Just recognize the names and what they're used for. Moving on to Parkinson's. If you're not familiar with Parkinson's, it's a neurological disorder that involves fine, slow-spreading muscle tremors, rigidity, and generalized slowness of movement called bradykinesia. It's a devastating disease. Usually it interrupts quality of life, and that's the most concerning factor. It does not necessarily mean that it's fatal. It just really means that living can be rough because the patients are so shaky. If you think back to Michael J. Fox, he was the sort of the billboard poster man for this disease. Patients develop a tendency to fall, dementia, confusion, psychosis, sleep disturbances, and declining cognitive function. Most patients progress to severe disability within 20 years. There is no cure. All we can do is relieve symptoms and maintain mobility. The overall cause of Parkinson's disease is not understood, but usually normal dopamine activity as it relates to acetylcholine is diminished, and overall relative overactivity of anticholinergic output is results. So what happens is dopamine starts to decrease, anticholinergic and acetylcholine left unchecked creates a lot of anticholinergic problems. Let me make sure I'm explaining that right. Causes a lot of cholinergic increase, and therefore that's why we see symptoms. We want to rule out drug-induced Parkinsonism before we diagnose chronic long-term Parkinsonism. Causes of drug-induced Parkinsonism generally include dopamine receptor antagonists and other drugs that interfere with dopamine synthesis or release. Agents include antipsychotics, calcium channel blockers, anticonvulsants, lithium, metoclopramide, and antidepressants. Always take a look at a patient's drug regimen before just saying, oh, they have got Parkinson's, and there's no question about it. Drug of choice to start with in Parkinson's patients: carbidopa-levodopa. Levodopa crosses the blood-brain barrier where it is converted to dopamine. Remember, we have a decrease in the amount of dopamine in Parkinson's, and we want to make it more available, bring it back up. Carbidopa enhances the effects of levodopa, so carbidopa makes levodopa better. Levodopa crosses the blood-brain barrier and becomes dopamine, thereby cutting down on the symptoms. The drug is called Sinemet, that's the brand name. Hasn't been branded for a very long time, mostly seen as carbidopa-levodopa. Side effects of Sinemet can include dyskinesias, which are involuntary movements, nausea, vomiting, anorexia, behavioral changes, hypotension, dizziness, syncope. There's also the potential for neuroleptic malignant syndrome, which is caused by abrupt discontinuation of the medication, and you can read about that right on that page. Patients who have received this medication for a long time may experience wearing off. Basically what happens is they get used to the medication, they develop a little bit of tolerance, it starts to become ineffective, and their symptoms return sooner rather than later, whereas the drug may have used to last for a few hours. Now it's only lasting for an hour. So sometimes we'll change the dose, increase it, change the timing, add an extra dose at the end of the day, or add another agent from one of the drug classes that we're going to discuss. Dopamine agonist is the first one. The newer dopamine agonists, pramipexole and ropinirole, are commonly used in conjunction with levodopa to delay that wearing off problem. It can also allow us to start off with a lower levodopa dose in the beginning. That way we don't have to be at high doses right off the bat. Older dopamine agonists, ergot derivatives, are bromocriptine. They're used much less frequently due to serious adverse effects. Some experts recommend dopamine agonists as initial monotherapy in patients less than 60. However, it's kind of going to be individualized to the patient. Read through the side effects and interactions. There is a patch available that's dosed once daily, and it could be a little more convenient for patients who have trouble swallowing or patients who have trouble remembering to take their medications by mouth. Monoamine oxidase B inhibitors. MAO-B is responsible for the breakdown of dopamine and tyramine in the brain. Therefore, MAO-B inhibitors will increase the amount of dopamine. Specifically, selegiline and rasagiline. Again, these come along with some interactions, so got to be careful with that. Also, some side effects as well. When given at the recommended dosages, there's minimal danger of hypertensive crisis or with other interactions of other MAOIs in certain foods. So the food restrictions aren't there as heavily as with MAOIs that we talked about for depression. So, anticholinergic agents. Drugs with anticholinergic and antihistaminic agents were the first to be used for PD and are still useful in the early stages of the disease. However, keep in mind they come along with a lot of anticholinergic side effects: dry mouth, dizziness, constipation, blurred vision, etc. If you think about Parkinson's disease, this can lead to tired, older patients at risk for falls. So again, caution with those. Amantadine. It alters dopamine release and has anticholinergic properties. It's used to treat Parkinsonism associated with prolonged use of phenothiazines, carbon monoxide poisoning, or cerebral arteriosclerosis in older adults. Generally used early in the disease as monotherapy, its efficacy may only last for a couple weeks or up to a few months. Little benefit when added to levodopa. COMT inhibitors. This is a long word. Catechol-O methyltransferase inhibitors, entacapone and tolcapone. They block the enzyme responsible for metabolizing peripheral levodopa, therefore increasing the concentration of levodopa and thus dopamine. This can allow the patient's dose of levodopa to be lowered and results in a decrease in the incidence and severity of side effects of levodopa. There's actually a combination med that includes entacapone, carbidopa, and levodopa, which makes it super easy for patients. A lot less medication throughout the day. Moving on, restless legs. This is one of those diseases that a lot of people take for granted and think, oh, it's not real. But patients who have restless leg syndrome literally go to bed and they can't keep their legs still, or it starts to happen more at night. It's described as an aching, burning, pulling, itching, or tingling. And it's triggered by rest or inactivity. Think about it. You sit on the couch at night, all of a sudden these people are suffering from jerky leg syndrome. It can be disruptive to sleep, and we try to treat it with those dopamine agonists that we talked about for Parkinson's, ropinirole and pramipexole. Brand names for those are Requip and Mirapex, as well as that patch that's available. However, usually they stick with oral meds here. RLS can also be secondary to other causes such as vitamin deficiencies, sometimes dehydration, so we want to rule that out before we start treating. Last but not least, Alzheimer's, another devastating neurological disease. And they keep it short and sweet here, but really Alzheimer's could be discussed for a while too. So Alzheimer's is characterized by a cognitive decline. Patients develop dementia, they can no longer remember. They start also declining in their ability to take care of themselves and feed themselves. Although the precise etiology or cause of Alzheimer's is unknown, cholinergic systems appear to be the most clearly compromised and are frequently the target of drug treatment. So how else can we help these patients? Generally, the cognitive decline can lead to psychosis-like symptoms, so we want to maintain a stable, stress-free environment, avoiding noise and light glare, as well as decreasing access to, providing security basically, decreasing access to the ability to hop in a car and drive or walk out the front door. We want them to have good sleep habits. Medications, the two they discuss here are cholinesterase inhibitors and NMDA receptor antagonists. Cholinesterase inhibitors were the first class of agents shown to be effective for Alzheimer's. They prevent the breakdown of acetylcholine in the synaptic cleft, thereby increasing acetylcholine levels and improving cognitive function. There is no treatment for Alzheimer's. All we're doing is hopefully preventing the symptoms and making the patient's quality of life a little better, but we cannot cure Alzheimer's. We don't have a cure yet, I should say. The drugs that you'll see used today that are cholinesterase inhibitors are donepezil, galantamine, and rivastigmine. They do exhibit cholinergic side effects as well as dizziness. However, not as bad as the original drugs that were in this class. Also, GI upset requires slow dose titration of these medications. Namenda, think about it, NMDA receptor antagonist. So Namenda fits that word perfectly, NMDA. And it is the first N-methyl D-aspartate antagonist, usually used for moderate to severe dementia, whereas cholinesterase inhibitors can be mild to moderate. They selectively block the cytotoxic effects associated with abnormal transmission of the neurotransmitter glutamate. Side effects include confusion, falls, agitation, dizziness, headache. However, it's pretty benign when it comes to the fact that it's good at least delaying the progress or treating the symptoms of Alzheimer's. So, I think that covers this chapter. Again, a lot of ground to cover for just one chapter, but the more you see these medications, the more you'll become familiar with them. this covers week 6. You guys are almost there, one more week of lectures. And if you have any questions, feel free to email me. Otherwise, I'll see you in week 7.